So my name is Carmen Parsels. I am a radiation therapist now for about 27 years. I work for the Ohio State University Wexner Medical Center for the James Cancer Hospital, but I am at the Stephanie Spielman Comprehensive Breast Center for almost 12 years now. And oh, there we go. I just want to say that I have no conflict of interest to disclose for this presentation today. So in 2011, the Stephanie Spielman Comprehensive Breast Center opened. It was the first of its kind in the Midwest to provide diagnosis, screening, and prevention, screening, and then detection, diagnosis, and treatment all in one building. I was fortunate enough to come over and before our actual department opened, and I've been there ever since. So with a new building comes new technology. So I'm a huge lover of new technology, and while I would love to be able to grab it and go, there's always some resistance to new technology. So I felt the best way to proceed was to try and prove the benefit of using Vision RT in our setups so that maybe we could go to tattoo-less, markless treatments. So for supine breast cancer treatment, the challenges that we face, it's not limited to, but the reproducibility of large pendulous breasts, any skin folds that might lead to skin reaction or poor cosmetic outcomes. Our arm and wrist cups are not fixed on our supine breast board. And shoulders may relax between CT sim and treatment, especially for those mastectomy patients that the surgical oncologist has put them on weightlifting restrictions. So in the time between CT sim and treatment, they're starting to use that arm more. And for a therapist, it can be challenging sometimes to get that arm and shoulder in the same position every day. And then, of course, DIBH technique adds challenges all on its own. So our OSU Breast Center imaging policy for our 3D conformal plans is that we do an orthogonal pair, a regional nodal field, and one large treatment field, alternating between our medial and lateral fields. We do those days 1 through 3, and as long as all moves are 3 millimeters or less, then we resume with our just weekly imaging. And any repeat imaging is done the next day if any shift in any direction is more than 3 millimeters. So I know 3 millimeters is very tight. It can be very challenging, but we pride ourselves on being able to achieve that. But it is a challenge on some patients, that's for sure. So our imaging policy for the IMRT plans is that we do an orthogonal pair and a cone beam CT. And then those are done days 1 through 3. And then we'll resume with the daily orthog pair and weekly cone beam if the shifts from the cone beam are less than 3 millimeters, and then otherwise we would resume with the daily cone beam and weekly orthogs if the shifts are greater than 3 millimeters. So basically, if it's greater than 3 millimeters, our cone beam is our imaging of choice. Otherwise, if we can get it down under 3 millimeters, then we'll stick with orthogs. So the equipment that we use, of course, coming over to a new center, everything was new and great. So we have the supine Civco breast board. We use their chin mask and their vac bag. And then we were introduced to the Varian True Beams. And then, of course, this crazy thing called Vision RT, which I had never heard of up until that point. And again, it was 2011, so it was a while back. So basically, Align RT is just your 3D camera system that tracks your position before and during treatment, and it aids in accuracy. That came straight from Vision RT's website. In comparison, postural video gives you a multi-angle real-time view of the patient's setup in correlation to their reference position from your CT sim, and it gives you contour lines to try and help you align the patient for treatment. Again, that comes straight from Vision RT's website. So here I put them side by side just to show you the difference in the way that they look. For the Align RT, the therapist will draw the region of interest on before the verification sim. And then for the postural video, those pink contour lines are displayed by the postural video feature through Vision RT. So here we go on to the study. So our focus for the study was the reproducibility of the arm, shoulder, and hip position for our daily supine breast treatments, using the postural video to aid in final adjustments before imaging. So our goals overall were to decrease repeat imaging, decrease the overall treatment time, decrease patient exposure, and increase the workflow efficiency by creating fewer images for the doctors to review. We are a very busy center. We have 2 treatment machines, creatively named TrueBeam 1 and TrueBeam 2. And it's a funny thing that when they built the new James, they got 7 TrueBeams, but they were able to give them all Ohio State Buckeye names, but we're still just good old TrueBeam 1 and TrueBeam 2. But you know, treating all those patients, it could be a mass quantity of films that bogs down the doctors when they're trying to plan and do other things. So just a little table for imaging dose. A KV planner image can be anywhere from 1 to 3 milligray. And then imaging dose for a 6 MV portal pair can be anywhere from 1 to 5 centigray. And an imaging dose from a cone beam can be anywhere from 1 to 9 centigray. So if you're struggling with a patient's positioning, especially something as mobile as your arm and shoulder, you could be taking multiple images to try and get them aligned. And so you are adding to their total dose overall. So our daily treatment workflow, it basically was the same between our traditional workflow with Align RT versus the study workflow with the postural video. So we always align our patients using the breastboard number, their tattoos, and using the lasers. Then we do calculated shifts to the isocenter daily. And then in the traditional workflow with Align RT, we do adjust the table to go with along the Align RT surface, but our department policy is we cannot move it more than 3 millimeters. If it is more than 3, then if they're not scheduled for imaging that day, we have to image them. So then in the study workflow, the very last thing is we do shift the table because you still have those table parameters. And then we turn on the postural video and we adjust the arms, shoulder, and hips if need be. So it really only adds on a second or 2 to your overall setup time. It really doesn't add on to our time at all. So here I just wanted to show that on the left-hand side, you'll see that the elbow is just shy of being where it needs to be. And then if you just drop it down a little bit, you'll see on the right-hand side that you get perfect alignment. And I know in this instant it led to a perfect image and we were able to treat. So again, on your left is obviously the goal that we want to achieve. That's the DRR from the treatment plan. Potentially with not using postural video, in the middle there you can see that the clavicle, or I hope you can see, the clavicle and the humeral head are too high. But I know in this instance for this image on your right, we used the postural video and we got that clavicle and the humeral head in perfect position. So with the dosimetric impact of incorrect arm positioning, this case was a left-sided mastectomy regional nodal patient that was treated with DIBH and VMAT. And in the time since she was CT'd to when we started her, she had been going to physical therapy, and her arm and shoulder were in a different position. And as therapists, we were struggling every day, taking multiple images, trying to get her shoulder to realign. So here, as the video plays, you're gonna kind of see how the humeral head and the scapular are misaligned, which is gonna lead to a lack of coverage on your supraclav volume. So you can start to see there where the scapula is coming off alignment. Humeral head's a little off there. And as we get down in there, the scapula gets worse. And your humeral head is off there too, so. And I think we're, all right. It's just playing out. She's doing the blender bar, okay. So then, just another look at, the dosimetrist did a verification plan to see, and the dotted line is the original treatment plan, isodose, and then the solid line would be the verification plan as where her shoulder was at that point. You're getting less coverage, but then at the end, you're getting increased hotness. Could we have used the same plan? Sure, it fell within tolerance, but therapists are gonna fight with that patient's shoulder every day to try and get it to align. And if you can replan it, why not? Let's get it right, we want it perfect. So we did replan that patient and then carried on with her treatments. So now on to my study. So for this study, there were 34 patients that were treated on the machine that I was working on from the beginning of the year till March 17th, using the postural video feature. So 330 images were obtained after verifying and/or aligning to postural video. These were patients that I was present for every time that was documented. I know that we used postural video, and we imaged that day, so we could see how well it was working. So if the patient's arm or shoulder needed adjusted, we went into the room, adjusted the patient, and then imaged. If adjustments needed to be done after the imaging, then you had to go back in the room, readjust the patient, and then imaging was then repeated. So the images are going to be evaluated by the number and the % of repeat images needed for proper alignment. So our results, we had a total number again of 330 images. 48 of those images were repeats, which gave us a repeat image percentage of 14.5. Now again, that may sound very small in number, but when you're treating the mass amount of patients that we do, it can be a lot of images. So, but in this case, it is a low number for us. So in comparison, we have this data, so what? So we decided to do a comparison of patients before, when we weren't using postural video, and after, so that we can compare repeat percentage rates. So in this study, we dropped it down to 30 patients because we have the 2 true beams, and we do share patients. Since we are a breast center, we can move our patients between the 2 true beams. So 4 of those patients in the original study were from the other treatment machine, and they were randomly treated, so I didn't have enough data that I felt that it was valuable to the study. So I dropped 4 of those patients, and each of those patients I tried to match with a patient that was treated last year when I know that we did not use the postural video, and I matched them per side, so right or left, chest wall and nodes versus intact breast and nodes, and conformal versus IMRT, and then the same number of fractions. So then I went through and documented all images for those patients. And in 2022, it amounted to 319 images that we reused after using just the Align RT feature. And then in 2023, we had 297 images using the postural video feature. And again, the 2023 data was, I was there, I know we used it, and we imaged the patient. So the results we got with that was in 2022, without postural video, we had the 319 images, 75 of which were repeats, so that gave us a percentage of repeat imaging at 23.5%. And then 2023, the 297 images, we then had 49 that were repeat, and that gave us 16.5%. So a decrease by 7%, which again, to some people may seem very small, but we thought this was pretty huge for us. So, I mean, 7% is 7%. So just some things, there's always a learning curve with new technology and new equipment. So on the left, there is a patient that was planned for the TrueBeam 1 system, and an SGRT surface was captured. You've got beautiful contour lines. You even have your RPM box that's contoured in. But what we discovered is when that patient is treated at the other treatment machine, when we pulled it up, the contour lines weren't as complete. And it does have the disclaimer at the bottom of the screen that it was captured on a different system. However, this was a left-sided patient. We had enough contour lines there for her arm, and we're able to still use postural video to align her that day. And then, so again, learning curve. We give our patients blankets if they request. So on the left there, you'll see on her arm all of those squiggly noise lines, and we realized that when it came time to capture an SGRT surface, we had to make sure there was nothing covering the arms. And sometimes you'll see on the left arm there that sometimes it contours the vac bag instead of her actual arm. However, we had enough there of the arm and the elbow that it didn't interfere with treatment. And so it'd be nice if maybe for future versions, if you could kind of edit and take out all the little extra noise that you don't need, but you learn to work around it. The other thing we noticed was that when you're standing table side and you're trying to adjust the patient, it's hard to tell if that shadow area is body or if it's actually a shadow. So our monitor is set on a counter away from the treatment table, so we were dependent on another therapist to be able to say, you need to bring her hips to the right a little bit more, or no, that's just a shadow, you're good. And the shadows could be created because of our lighting in our treatment rooms, but this is our current workflow, and so it was just something that we noticed. But again, once you get used to it, you can work around it. So just some last minute things to consider. We had a patient that we were setting up one day, and during her practice DIBH breaths, she could not hit the threshold. We noticed that the box was not in her contoured RPM lines. We moved the box over, and then she was able to hit every time. So that would help with DIBH technique. There was another patient that they kept telling me, you gotta drop her elbow, you gotta lower her arm, it's too high, and I couldn't get it down any further. So we paused the video feature, rechecked her setup, and whether the arm cuff was misset from the beginning or when the patient laid down, she bumped it. But once we corrected that, turned the video feature back on, she was in alignment, and then we were able to proceed with treatment. It's also really good for patients that are coughing, because when patients cough, their shoulders can move, whereas with just Align RT, you're just seeing like a surface rendering, where this is live video feed. So for any movement or coughing, we found that it was really good to be able to monitor the patients a little better. And then I just wanted to stress, for any of our patients that were non-daily imaging, if we repeated imaging that day, we had to repeat it the next day. So it does cause not only repeats that day, but then the next day, and then the next day, and potentially the next day. So.